question and answer. Better still, you can also put your questions on the chat box. When they come to your mind, we will read them during the question and answer sessions. We'll appreciate your feedback also at the end of this meeting. So we'll be sharing a link to get your feedback at the end of both presentations. Moving on, I'll be handing over to my colleague Femi to give us a welcome address. Over to you, Femi.
Hey, thanks a lot, Dr. Osagi, for that introduction. So, good afternoon, good evening, doctors on call, both from Nigeria and joining this early. We want to appreciate you for taking time out of your busy schedule to prioritize being in this meeting today. We know it's a 2 days meeting. Today is the first session for the GP Masterclass, and tomorrow will be the day 2, which will be the climax. So basically, we at Novartis, as we always say, we are leaders in the art of reimagining medicine. We are inspired to help to bring positive change to the life of patients in the community where we serve, especially in West African region and Sub-Saharan Africa as a whole. So I bring greetings from Sub-Saharan Africa medical lead Dr. Fafa, who is unavoidably absent, and also from West Africa medical lead Dr. Jerome, who is also they send their warmest greetings. And basically, for these next 2 days, we'll be we'll be having specialists across the field of hypertension, diabetes, sickle cell, even also around eye care, educating us and helping us to upskill knowledge and practice around these common disease areas. So basically, it's for us to be able to know what's up to date around this area and how it will help us sharpen our clinical practice going forward with the sole aim of improving patient outcome and also helping us to also be better physicians in our practice. So basically, that's the overarching goal of this GP Masterclass, for us to be on top of the game of our clinical practice and also for our patients to get the best from us and from the health service where we work. So for us as Novartis, we are leaders in the industry of healthcare, and we believe that this kind of engagements contributes positively to your clinical practice, your career, and also eventually help to improve patient outcome. So once again, we thank you. We want you to take your seat, relax. Today we'll be having, just as the agenda is showing, we'll be having 2 sessions. The first will be around hypertension, and the second will be around dyslipidemia. We have 2 esteemed and experienced speakers who are already in the room and will be leading us in that in those sessions. And thereafter, we'll be having a Q&A session where every one of us can come in. You can raise your hand, you can unmute your mic at that time, and also put your question in the chat box. So it's meant to be actually a very engaging period in the next 2 hours thereabouts. So once again, I welcome you. Thank you for joining. And hopefully by the end of the next 1.5 to 2 hours, you will have learned a lot and you will have gotten something positive from this meeting. Once again, thank you, and I hope you have a great time this evening. Over to you, Ose.
Thank you very much, Femi. Yes, so without wasting much of our time, we'll be going over to our first talk for today. So our first speaker. Our first speaker is Dr. Francis Ajekum, a consultant cardiologist at the Kolibu Teaching Hospital and a lecturer at the University of Ghana Medical School, College of Health Sciences, Legon. Dr. Ajekum holds a postgraduate certificate in interventional cardiology from the Guangdong Cardiovascular Institute in China and is pursuing a postgraduate diploma in preventing cardiovascular medicine from the University of South Wales, UK. He has co-authored many publications and contributed to Ghana's first comprehensive cardiovascular disease management guideline. He has served in various capacities across all levels of healthcare in Ghana and is actively involved in research. His interest includes preventive cardiology, heart failure, non-invasive cardiovascular testing, and coronary interventions. Dr. Ajekum is the Vice President of the Ghanaian Society of Cardiology and a member of both the International Society of Hypertension and the European Society of Cardiology. He is married with 3 children. Please help me make welcome Dr. Francis Ajekum.
The last 3 months and increased weight over the last 6 months.
Dr. Ajekum, over to you.
All right. Can I share?
Yes, please. I'll stop sharing.
All right. Thank you very much for the introduction. I believe you can see my slides.
Yes, please.
Yes, sir. Perfect.
Okay, that's fine. Good. So, good evening to you all, both Ghana and Nigeria. And I'm happy to be part of this meeting. As has already been said, I'm going to be talking about the current trends in the management of hypertension. This is a disclaimer that all the views are mine. They are not that of Novartis. Unfortunately, my slides have gone away. I don't know what happened.
Okay. Can I share for you?
I don't know what happened. The screen has just gone away. I'm just seeing other screens. What's happening?
Okay.
Maybe you're trying to
Let me.
reshare again.
Okay, let me try and reshare.
Okay, it's coming up now.
Okay. Okay, good. So as I said, the slides are mine, and Novartis cannot be held responsible for any content I deliver this evening. So the main objective of this will be to discuss the new guidelines in the management of hypertension. We also look at how to apply this guideline and 75 diastolic tends to be associated with increased cardiovascular risk. Indeed, it's been known that every 10 millimeter increase above this value is associated with a doubling of one's cardiovascular risk. So several societies have tended up to define hypertension based on epidemiological data and so many other factors. And as this slide shows, there are a lot of definitions, a lot of societies, and their definitions tend to differ a little bit. The 2 most common ones are the American Heart Association, American College of Cardiology guidelines, and also the European Society of Cardiology. But there are other societies, as you can see here. So if you take a look at the systolic blood pressure, I think this slide is busy, so I decided to just focus on the 2 most common ones, which are the American Heart Association and the ESC guidelines. So with the American Heart Association, optimal blood pressure or normal blood pressure is when systolic blood pressure is below 120 millimeters of mercury and diastolic below 80 millimeters of mercury. Elevated blood pressure when the systolic is between 120 to 129 and the diastolic is less than 80. And then they define stage 1 hypertension as systolic blood pressure of between 130 to 139 millimeters of mercury and a diastolic blood pressure of 80 to 89. And the caveat is and all. So any of these values will qualify the person to be stage 1 hypertension. And then stage 2 hypertension is systolic blood pressure 140 or above, and the diastolic blood pressure 90 or above. You see that that is a little different from the European Society of Cardiology guidelines. Now, their latest guideline in 2024, they've shifted away from the stage 1, stage 2, stage 3 hypertension. Now, what they have is either blood pressure is non-elevated, elevated, or hypertension. And when you say non-elevated blood pressure, they all agree 120 systolic, less than 70 diastolic. Elevated blood pressure is between 120 to 139 systolic, and then 70 to 89 millimeters of mercury diastolic. This also encompasses the stage 1 hypertension by the American Heart Association. And of course, hypertension is when your systolic blood pressure is 140 millimeters of mercury or above systolic, and then 90 millimeters of mercury or above diastolic. We do know that globally, cardiovascular diseases are the leading causes of death. And indeed, this is driven mainly by ischemic heart disease, stroke, and the rest. And also, cancers and other things are contributing to a lot of deaths. But cardiovascular diseases alone constitutes about a third of all the deaths that are occurring in this world. And this is mainly driven by hypertension, especially in Africa. In fact, if you ask any African what is the common cause of cardiovascular diseases, hypertension number 1, hypertension number 2, hypertension number 3. So hypertension is the main driver globally of cardiovascular disease. Other risk factors, smoking, high cholesterol, high blood sugar, air pollution, and things also contribute their quota, but hypertension still leads the chart of cardiovascular disease burden. If you take a look at the global burden of hypertension, Lancet published a paper and looked at what is the burden of hypertension globally. It's now currently around 1.56 billion people living with hypertension globally. And if you take people who are between the ages of 20 and above. So it is a very common condition that is affecting a lot of people. Majority of them are living in low and middle income countries. About 2/3 of these people with hypertension are living in low and middle income countries. And in 2015 alone, 1 in 4 men and 1 in 5 women had hypertension. This indeed has increased. The latest paper I looked at, now we are looking at 28% of the global population having hypertension. And the sad story is that less than 20% of people who have hypertension have the blood pressure under control, despite the fact that hypertension is a major driver of cardiovascular diseases. And so it is important that we all are very aggressive in controlling blood pressure and preventing its consequences. This is data I picked from the Lancet paper I referred to. It compared the year 2000 to 2025, and you realize that there hasn't been much change. And you are looking at sub-Saharan Africa is here, about 27-28% of the people, both men and women, are living with hypertension. The prevalence between men and women is not that different. And the sad story is we haven't made much progress when it comes to addressing the issue of hypertension. So it's important that we all put our acts together. And the story of Ghana is not different. A systematic review was done by Bosu, and the pooled prevalence of hypertension was 27%. And indeed, if you look at the people who had hypertension and the control rate, only 6% had their blood pressure controlled. This is a very sad story. knowing that hypertension is a major driver. What are the types of hypertension? There are several types. We have the most common one is the essential hypertension. About 90% of patients with hypertension will have essential or primary hypertension, which we do not really know what causes the hypertension, but there are several risk factors that may contribute to its causation. Then we have secondary hypertension. That constitutes just about 10 to 15% of patients with hypertension, and this is the group that have an underlying cause to the hypertension. So if you're able to reveal that underlying cause and deal with it, you will be able to cure the hypertension in that case. Then other phenotypes may be resistant hypertension, masked hypertension, people who record normal blood pressures at the clinic, but when you do ambulatory blood pressure, you see elevated blood pressures. White coat hypertension is the opposite, where people come to the hospital, you check their blood pressures is high, and then when you do ambulatory blood pressure, their BPs are normal. Then labor hypertension, paroxysmal. So there are several other types of hypertension. The important one we are going to be focusing our attention on is essential hypertension, and then we'll make mention of resistant hypertension, white coat hypertension, and mass hypertension, but not to a very detailed extent. I mentioned that most of the time we do not know the cause of the hypertension. That is why it is called essential or primary hypertension. But there are risk factors that contribute to this pathology. We have risk factors that have strong evidence of association. If somebody has a high normal blood pressure, what we use to term pre-hypertension status, then that person's risk of developing hypertension is high. Elevated BP during medical care, that's a white coat hypertension. People who record high blood pressures, formerly we said that white coat hypertension, no, ignore it. Now we do know that it is also a risk factor for developing hypertension. Obesity and overweight, alcohol use, insulin exposure or insulin resistance, all these are risk factors for developing hypertension. And then there are other risk factors that tend to have limited evidence, like elevated urinary sodium excretion, high red meat intake, and other diseases like psoriasis. If your sleep duration is less than 6 hours per night, that is sleep deprivation, it increases your risk of developing hypertension. If you are somebody who takes NSAIDs frequently, that also may increase your risk of developing hypertension, but these are with limited evidence. What is the pathophysiology of elevated blood pressure? I have stated that there are risk factors. So we have multiple factors: genetic factors, behavioral factors, socioeconomic factors, environmental factors. All these contribute to the development of hypertension. And then the mechanisms are also very, you have renal mechanisms and so many other mechanisms that are contributing to the development of hypertension. I do know at this stage, if you go too much into pathophysiology, people begin sleeping. So just get enough to know that hypertension is a multifactorial problem where genetic factors contribute, behavioral factors, socioeconomic factors, environmental factors contribute to the causation of hypertension. So with that,
sorry,
I
Dr.
think I can.
Your slides are not moving.
Oh, really? It's moving from my end. Which slide are you seeing now?
I'm seeing like is it the ultrasound or the radiograph stuff?
Slide 20.
Slide number 20. Slide number 20. That's what is visible now.
Wow, I'm on slide number. Okay, number 20 is the ultrasound.
Yes, please.
Yeah, that's it.
Stop
Wow.
sharing now.
Ah.
Maybe you will share again.
What is happening to Teams today? Okay, so which slide can you see now?
Slide 3.
Number 3,
Four.
number 4.
Okay, it's moving
It's
now.
moving now.
Okay, it's moving now. Okay.
All right, good. So we were talking about the pathophysiology of it. So the images, you can see them now.
Yes, please.
Echo images. Okay, so this is just to show the pathophysiology. While if you take a normal person, the heart walls are quite thin, but with hypertension, there's thickening of the walls. This is called left ventricular hypertrophy, and that can lead to diastolic dysfunction and eventually systolic dysfunction, heart failure, and other consequences of hypertension. This slide shows an aneurysm in the brain, which can rupture and lead to cerebral hemorrhage and then stroke as a result of hypertension. So sometimes atherosclerosis as a result of hypertension will lead to cerebral infarction, or, as I said, rupture of an aneurysm leading to a stroke, hemorrhage. All right. So this slide I picked from ESC guidelines, the 2024 guidelines, and it shows us the consequences of hypertension, the various end organs that can be affected by hypertension. The eye, it can lead to retinopathy and blindness. The heart, I've already mentioned, it can cause left ventricular hypertrophy, left atrial enlargement, heart failure, coronary artery disease, and the rest. The brain, it can lead to microinfarcts, microbleeds, vascular dementia, ischemic stroke, hemorrhagic stroke, and the rest. Then the large and medium blood vessels, atherosclerosis, can actually lead to rupture, aortic dissection, and rest. The kidney is also another organ that is really affected by hypertension, and that can lead to kidney failure. So hypertension indeed causes a lot of problems, and it needs to be tackled. So the issue is, how do we diagnose hypertension, knowing all these issues? Unfortunately, there is no blood test that can diagnose hypertension. You need to measure the blood pressure, and you need to measure that blood pressure accurately to be able to diagnose hypertension. So let's take our time. Let's get the patient well prepared to sit in a very comfortable room. If the room is too hot or the room is too cold, it doesn't help with good blood pressure measurement. The seating position is very important. They should sit straight with their back supported, with their legs on the floor. They should not cross their legs. The arms should be bare, and then use the appropriate size of cuff to measure the blood pressure. Now, most guidelines prefer the use of the electronic gadget, but if you don't have it and you still use the manual, you should be able to listen to the heart sounds, the coracle sounds well, and determine your blood pressure. But most guidelines now prefer the electronic gadget. Make sure that if you are using the electronic blood pressure monitor, your battery is good. It is not dead. Otherwise, you are not going to get a good blood pressure measurement. And we do not recommend that you take just one blood pressure measurement to diagnose hypertension. You need to do multiple measurements. So let the person rest when they come to your office for about 3 to 5 minutes. They sit down and rest, and then you check the first blood pressure, you discard that, check the second one, check the third one, take the average of the second and third one, and that should be the blood pressure for the person for that particular day. And you don't use one blood pressure to diagnose hypertension. There are common mistakes that people make in checking the blood pressure, and these mistakes are associated with increased blood pressures. So, for instance, if the person crosses his or her legs when you are checking the blood pressure, it's associated with about 3 to 15 millimeter increase in the blood pressure. If the person is talking, sometimes you see patients having their blood pressure checked and they are on the phone talking. That increases that person's blood pressure by up to 19 millimeters of mercury. If that person is fidgety, not resting. And another common mistake people make at the clinic is when people are in long sleeps, they do not take their shirt off. They put the cuff on the shirt or the clothing. That is not a proper way to check the blood pressure. So let's make sure that we follow the guidelines well and check the blood pressure well so that we get the accurate blood pressure, because that is the way to diagnose hypertension. So the American Heart Association produced key steps for proper blood pressure measurement. And step 1, properly prepare the patient. As I've already said, make sure that your patient is not anxious, your patient is seated comfortably, make sure the room environment is good, and all those things. So step 2, use proper technique for your blood pressure measurement. And that we have discussed already. And then take the proper measurements needed for diagnosis and treatment of elevated blood pressure. So don't just use one blood pressure. You need to take multiple blood pressures. Properly document accurate blood pressure readings. Indeed, sometimes people check, they don't document, and then they have forgotten. So they write something down. That may not be the true picture for that person. And always remember, averaging your readings is the clue. You must always average readings. Never use a single blood pressure check for a person. And once you have done this, it is always nice and important to provide BP readings to your patient. Patients shouldn't go around saying that I don't know what my blood pressure is. Now, what is the protocol for hypertension, confirming hypertension diagnosis? You've checked the person's blood pressure. This is also from the 2024 ESC guidelines. So if you check and the person's blood pressure is less than 120/70, depending on is this person 40 years and above or less. If that person is less than 40 years, really you don't need to be monitoring the blood pressure so frequently. They recommend every 3 years check the blood pressure. But if that person is above 40 years or above, then annual blood pressure opportunistic screening is very, very important for such a person. If you check blood pressure and it's elevated BP, that is between 120 to 129 millimeters of mercury, the other thing you need to do is, what is the person's risk like? So you risk assess the person. Is this person a low risk person, intermediate risk person, or a high risk person? If the person is a low risk person, then that person will need annual blood pressure check. However, if this person is intermediate or high risk person, then you need to confirm this blood pressure, elevated blood pressure, with ambulatory blood pressure measurement out of office. So it could be home blood pressure measurement or it could be ambulatory blood pressure measurement, and then determine the appropriate course of action, whether the person needs lifestyle modification or medical therapy plus lifestyle modification to control the blood pressure. Of course, if that person's blood pressure is high, then that person definitely has hypertension, and therefore you need to determine the next line of action. And that is similar to what the Americans also said, just that the cutoffs for ambulatory blood pressure requesting and those things are a little different, but basically they are similar. So the main thing is, if you do your ambulatory blood pressure measurement, compare it with your office blood pressure. If office blood pressure is normal, and then your ambulatory blood pressure is high, that person has what we call max hypertension. If your office blood pressure is high and the person has normal ambulatory blood pressure, then you are dealing with high code hypertension. Otherwise, high blood office BP, high ambulatory blood pressure, that is hypertension as well. So put all these ones into context and appropriately diagnose your patient. Having diagnosed your patient, anyway, this is just to give you the indications for ambulatory blood pressure measurement. I think I've mentioned all of them as well. The cutoffs, as I said, are a little different. American College of Cardiology, they are using the cutoff of 125/75 millimeters of mercury. So if your 24-hour ambulatory blood pressure is more than 125/75 millimeters of mercury, then that person has hypertension. The European Society of Cardiology and the Hypertension Canada, they use more than 130/80 millimeters of mercury, and that is what we tend to use in our practice as well. So if the ambulatory blood pressure, 24-hour ambulatory blood pressure is more than 130/80 millimeters of mercury or more, then that person has hypertension. How do you then go further with your evaluation of this patient? Let's remember that every increase in blood pressure is associated with increased cardiovascular risk. It is therefore important that you assess the patient's total cardiovascular risk, because hypertension does not walk alone. It tends to be associated with other comorbidities, and you need to be able to unravel those comorbidities as well. Indeed, 2 in every 3 patients with hypertension have a comorbidity. And in 2 in every 3 patients with a comorbidity, hypertension is one of the comorbidities. So if you take, for instance, patients with hypertension, about 50% of them have dyslipidemia. And about 30% of them have type 2 diabetes. Up to about 70% of them are overweight or obese. And therefore, if you are managing such patients, it is not just the hypertension, but all these comorbidities need to be tackled. The same way, if you take people with dyslipidemia, about 64% of them have hypertension. If you take people with diabetes, about 75% of them have hypertension. So hypertension tends to be associated with other comorbidities, and that needs to be made very clear. And there are some of these risks are modifiable. Others are not so modifiable. You need to be able to identify them and slow down the progression. So if you take the modifiable risk factors like hypertensive who also smokes cigarettes, it's a modifiable risk factor, whether it's a primary smoker or a secondary smoker. Hypertensive who is not physically active, that is also a risk factor. Diet, poor diet. So all these are important modifiable risk factors that we need to identify. In addition, if your hypertensive also has a CKD, it is important to identify what stage of CKD. Is there proteinuria? What is the eGFR? So that you'll be able to slow down the progression of the kidney disease and so many other things. So fully assessing your patient with hypertension is so essential for a global management of the patient, not just focusing on the hypertension. For many patients with hypertension, baseline investigations will include full blood count to assess hemoglobin and your hematocrit, fasting blood sugar, and glycated hemoglobin to determine whether this person has diabetes. Blood lipids, very important, LDL, cholesterol, HDL, and the rest. Also, your kidney function test is very, very important. Determine what's the potassium level, determine what's the urea and creatinine level, calculate your eGFR. These are important aspects of your management. And of course, proteinuria, if it is present, either you do urine albumin creatinine ratio or you do urine dipstick. These are all important aspects. And every patient with hypertension should have a 12-lead ECG done. at least to determine whether there is any abnormality with the heart as well. Unfortunately, this slide is one of the new ones, but it looks very busy. It's just to tell us what end organ damage or target organ damage or hypertension mediated organ damage. These names, they keep, they can be used interchangeably. The modern term is hypertension mediated organ damage. And the main organs, I've mentioned them already. And so if it is the kidney, you want to calculate your EGFR, you also want to check if they have proteinuria. For the heart, ECG, echocardiogram are very, very important aspects for your hypertension management. And so get to identify which comorbidities or hypertension mediated organ damage is there. And when you have done all these things, you then put them in this risk table to then categorize your patient. What stage is your patient? Is this person a low risk, a moderate risk, a high risk, or a very high risk patient? And that would then inform what target blood pressure you are going to aim at. Indeed, what threshold blood pressure you should even be treating. Even though the ESC guidelines say between 120 to 139 is elevated blood pressure, if that person is a very high risk patient and has a blood pressure of 130 over 80, you may want to control that blood pressure. There's some noise going on. I don't know whether somebody is trying to say something. Okay, good. Every 10 millimeter reduction in systolic blood pressure or 5 millimeter reduction in diastolic blood pressure is associated with cardiovascular benefits. 20% reduction in all major CV events, 10 to 15% reduction in all-cause mortality, 35% reduction in stroke, 20% reduction in coronary events, and 40% reduction in heart failure. These are huge benefits you don't want to deny your patient of. And therefore, treating hypertension is very, very important. And the modes of treatment are lifestyle management and medication. It is important. And lifestyle management is recommended for all stages of hypertension, whether the person has elevated blood pressure, has hypertension, or whatever stage of hypertension. Lifestyle management is recommended. And in addition to the lifestyle management, the use of medications will be determined by your patient's total risk and then the level of blood pressure and the target blood pressure one wants to achieve. So these are considerations that need to be made. So when we say lifestyle management or lifestyle modification, which ones are we referring to? Weight loss is very, very important. If you are able to lose about just a kilometer reduction in your body weight, you are able to reduce your blood pressure by about 5 millimeters of mercury. So it is important that you lose weight. Healthy diet, the DASH type of diet, low salt diet, this is also important to reduce your blood pressure. If you are able to reduce the intake of dietary sodium, that is important. Enhanced dietary potassium intake is also associated with reduced blood pressure. Physical activity, we cannot overemphasize that. It's very, very important. All forms of physical activity, whether it's aerobic, whether it's dynamic resistance exercises or isometric resistance exercises, all forms of exercises are associated with reduced blood pressure. And then moderation in alcohol intake. If you do not drink alcohol, do not start it. If you drink alcohol, try to reduce it if you cannot quit. Because now we do know that alcohol does not give any cardiovascular benefits. So it's important that you are able to stay clean of alcohol. And then the medications. So depending on that person's blood pressure, your medications also come in. Let me put this important caveat that I picked from the ACC guidelines, that when it comes to hypertension, the amount of blood pressure reduction is the major determinant of reduction in cardiovascular risk in both younger and older patients with hypertension, and not necessarily the choice of antihypertensive medication. In certain people, because of their risk factors, you want to choose certain specific medications, but whatever it is, bring that blood pressure down. The most important determinant of cardiovascular benefit is the blood pressure reduction, and not the specific choice of agents for the patient. If you look at the all-heart trial, they compare clothalidone, amlodipine, lisinopril. So these are diuretic, calcium channel blocker, and ACE inhibitor. And they were looking at the rate of MI or fatal coronary heart disease. And you realize that the line did not separate. They were equal. So once you get the blood pressure down, whether you are using a diuretic, a calcium channel blocker, or an ACE inhibitor, the benefit is there, and it's good for the patient. However, many patients require 2 or more antihypertensive agents to control their blood pressure adequately. Indeed, many of our patients with hypertension, for very good blood pressure control, will need about 3 antihypertensive agents to be able to control them. With optimal use of 3 antihypertensive agents, you'll be able to control about 80 to 85% of patients with hypertension, and that is what we should be aiming at. Unfortunately, there's a lot of inertia among clinicians. So there's benefit in combining the antihypertensive agents into single drugs. It affords you the opportunity to use lower doses and therefore reduce the side effects. You are also tackling the BP from multiple angles, mechanisms, and therefore provide more benefit. And then the inertia of doctors introducing new drugs, even when blood pressure is not controlled, that is also dealt with. And some of them, they sort of act synergistically, so they help to counterbalance the side effects of the others. So single pill combination has come to stay and is now the preferred mode of therapy.
Sorry?
Hello?
You hear me, Dr. Jacob?
Yes.
You have 5 more minutes, please.
Oh, really? Wow.
Yes, please.
Okay. Let me just round it quickly then. So this is the accomplished trial that also look at combination of 2 agents, ACE inhibitor and diuretic, and then ACE inhibitor and amlodipine, and show that amlodipine-based regimen provides greater benefit than the diuretic-based regimen. If you look at the Curely trial, which was also done in Africa, it also showed that if you combine ACE inhibitor, thiazide, there were more variability than if you combine with a calcium channel blocker. So amlodipine-based combinations tend to give you less blood pressure variability than the diuretic-based combination therapy. And this slide was quite a huge study that showed that even with the same agents, if you prescribe them as single tablets versus combination, single pill combination, the single pill combination showed better results than if you prescribe them as single agents. For instance, if you are giving a person amlodipine and lisinopril, choosing a single pill tablet containing amlodipine and lisinopril provided better outcome than when you prescribe amlodipine and lisinopril as single agents to the patient. So what do the guidelines recommend? If you look at the 2018 ESC, we should initiate all hypertensives with dual antiplatelet antihypertensive therapy. And the dual therapy is either ACE inhibitor or ARB plus a calcium channel blocker or a diuretic therapy. Only few patients will require single agent as an initial therapy. And then step 2 is you then go to the triple combination therapy. And then, of course, if there is resistant hypertension, then addition of other agents. This is similar to the 2020 International Society of Hypertension guidelines, the same recommendations. A is either ACE inhibitor or ARB, and C is calcium channel blocker. And then for them, start at half doses, optimize to maximum doses. If it's still not controlled, then triple combination, still as a single tablet combination, and then you add other agents when the blood pressure is not controlled. 2023 European Society of Hypertension guidelines, very similar. And in all these guidelines, beta blocker is used when there is indication to use a beta blocker, like if the patient has left ventricular systolic dysfunction or the person has ischemic heart disease, then beta blocker is quite high, or the person has tachycardia, for instance. Otherwise, the recommendations are similar. And this is the last one that came out, and that is the European Society of Cardiology guidelines, and they also say similar. So the only difference here is that for this guideline, what they are saying is that if start with low dose dual hypertension medication, if it's not controlled in 1 month, go to low dose triple combination and then start optimizing the dose. So that was the little at there. And of course, if at that point it's not well controlled, what is your ideal fourth agent? I think I've mentioned some of these things already. So practical approach to hypertension control, and I'll bring it to a close. So accurate blood pressure measurement for accurate diagnosis, risk stratification to risk assess your patient. All patients require lifestyle modification. So you determine who can have 3 to 6 months trial of lifestyle modification only, or who needs drug therapy right from the beginning in addition to the lifestyle modification. Most patients should be initiated with single pill combination dual therapy at low doses. That is, start with half doses of each of the agents and review 1 month to optimize the dose and change to single pill triple therapy if BP is not well controlled or on target. And if you follow this and that person's blood pressure is not controlled by the time you are using triple therapy, then that person probably has resistant hypertension. You need to assess compliance with medication. You need to do ambulatory blood pressure to assess whether there's white coat effect, and then addition of mineralocorticoid receptor antagonist is a good fourth agent. And of course, other agents like the alpha blockers and other things can be added as required. So in conclusion, hypertension is the leading cause or the leading risk factor for cardiovascular mortality. Accurate blood pressure measurement is essential for your accurate diagnosis and monitoring of blood pressure. Global assessment and risk stratification is an important aspect of blood pressure management. Lifestyle modification is an important aspect of the blood pressure management at all stages of hypertension. Most patients with hypertension should be initiated with single pill combination dual therapy at low doses. Thank you very much.
Thank you very much, Dr. Ajikun, for that beautiful presentation on hypertension. Please note that we are going to take our questions at the end of both presentations. So please, you can put your questions in the chat box, or you can wait till the end of the second presentation and raise your hand to ask the question. So we're moving on to our next presentation, and our second speaker is ready. So I will quickly share my screen. So our second speaker, can you all see my screen?
Yes, Osi.
Good.
Osi, can you hear me?
So yes, I can hear you.
Yes. Do you have Dr. Ramalan's latest
Yes, I do.
slide deck? Okay. Thanks.
So our second speaker is Dr. Ramalan. He is a distinguished physician, clinical pharmacologist, and endocrinologist. He serves as a faculty member in the Department of Clinical Pharmacology and Therapeutics at the Federal University of Lafayette, Nassau State. Dr. Ramalan's multidisciplinary career spans clinical practice, academic instruction, and medical research. He has held numerous teaching roles, guiding both undergraduate and postgraduate students in internal medicine, pharmacology, and therapeutics. He has authored and co-authored several peer-reviewed publications and has presented his research at national and international conferences. In addition to his academic and clinical roles, Dr. Ramalan has contributed to health policy development and served on various advisory and guideline committees, particularly focused on diabetes care in Nigeria. He currently serves as the chairman of the Non-Communicable Disease Committee of the Nigerian Medical Association. Please help me welcome Dr. Ramalan as he takes us on our next presentation. So I'll be sharing his slide. Dr. Ramalan, kindly confirm that you can see the slide.
Yeah, I'm seeing the slides. Thank you very much. I would want to thank Novartis for organizing this program. And I've listened to the first speaker who was very eloquent and depth in talking about hypertension. So I'm going to be talking about dyslipidemia management and the importance of risk stratification. I think we need to mute our
microphones. If you are not, kindly mute your mics and also that we can avoid distractions during this presentation, please. Kindly go on, Dr. Ramalan.
Okay, thank you very much. I'm going to the next slide. I welcome all participants from Nigeria and Ghana, and I don't have any shares in Novartis. And for this presentation, whatever I'm going to say in this meeting is a product of my own research. It's not the opinion of the company and does not reflect the company's position on any product that I may talk about. Thank you. The objectives of this presentation is just to ensure that people understand what dyslipidemia is all about, and the concept of cardiovascular risk stratification, and to know how to assess cardiovascular risk in patients with dyslipidemia, and how to apply these risk-based treatment strategies using guidelines, and finally to enhance individualized care and patient outcome. So the lipid profile consists of so many components: the total cholesterol, triglycerides, low-density lipoprotein cholesterol, and the high-density lipoprotein cholesterol. We have the non-high-density lipoprotein cholesterol portion, as well as the total cholesterol portion. So for good reasons, both the HDL and the high-density lipoprotein is classified as the good cholesterol, while the other components of the lipid profile are classified as the bad cholesterol. So dyslipidemias are primary lipid disorders. Either they are considered either as primary lipid disorders or secondary to underlying disease condition, and sometimes even due to some medications. And they are subcategorized based on the pattern of lipoprotein abnormality, and adequate control is achieved with lifestyle measures like you do for hypertension and diabetes, as well as for pharmacotherapy. And it is always good to consider a possibility of familial dyslipidemia in patients who have premature arteriosclerosis and history of vascular or coronary heart disease. Abnormalities in lipoprotein concentrations are found in almost 7 out of every 10 patients with coronary heart disease with a familial disorder, and in more than half of the cases in patients who have a familial disorder. So on the right side of the slide, you can see a blood sample that is lipemic. This is a sample from one of the patients we saw in the clinic, which I will share some images from the patients later. So the different types of dyslipidemia are, generally whether you are dealing with primarily a disorder of the cholesterol portion, which is called hypercholesterolemia, when the total cholesterol is high, or the low-density lipoprotein cholesterol is high. Or you may be dealing with primarily triglyceride levels that are elevated, so that is hypertriglyceridemia. In some instances, you may have a mixed pattern where you have both high cholesterol, total cholesterol, and low density lipoprotein cholesterol, as well as high triglyceride levels. So that is a mixed type of dyslipidemia. So there is this Fredrickson's classification of hyperlipidemia, and that classified dyslipidemia into 5 different classes, 6 classes, I mean. So you have class 1, chylomicrons predominantly, class 2A, LDL, class 2B, LDL, and very low density lipoprotein, class 3, intermediate lipoprotein, and then class 4, very low density lipoprotein, and class 5, cholesterol and very low density lipoprotein. For all these classes, the classes that are very important in high cardiovascular risk are low density lipoprotein and the low density and very low density lipoprotein cholesterol. So those 2 classes, class 2A and 2B, are the ones that have a very high cholesterol, I mean, atherosclerotic risk. Now, there are also some genetic dyslipidemias that should be also remembered, because we have some form of familial combined hyperlipidemia, and you also have heterozygous familial hypercholesterolemia. You also have homozygous familial hypercholesterolemia, polygenic hypercholesterolemia, and familial hypertriglyceridemia. So these are forms of genetic dyslipidemia. We should always remember, in patients who have coronary heart disease and familial history, the tendencies towards genetic dyslipidemias could be high. So I've decided to share these images with you, images of a patient that we've seen with a form of familial hypercholesterolemia. You could see the eruptive xanthomas around the periaqueous area. You can see in between the wet interdigital areas, and you can see on the flexural areas. This is around her, the anterior aspect of her upper arm. Now, I just shared another blood sample that I saw recently of a patient with dyslipidemia. You could see that the sample is lipemic even before analysis. So this is the posterior aspect of the patient that I shared with. You see the posterior aspect, that's the posterior aspect of popliteal fossa. You could see the eruptive xanthomas that are symptoms of signs, sorry, of familial dyslipidemia. Okay, so there's a form of classification for familial dyslipidemia, the Simon-Broom diagnostic criteria, which is important because if you see patients with total cholesterol that is up to more than 7.5 millimole per liter, you should think of things like familial hyperlipidemia. You can see that the criteria gives at least one of these 2 conditions if you are able to see tendons and tumors, like in the case of this patient that I've shared, either in the first degree relative or in the patient, or first degree relative for the patient or second degree relative for the patient. Or you are able to have DNA evidence of ApoB disorders or PCSK9 mutation. So either of these 2 is plus family history of myocardial infarction or family history of elevated total cholesterol is, excuse me, sorry, is indicative of familial dyslipidemia. Just briefly, there's a Dutch network for diagnosis of familial dyslipidemia. And again, first degree relative with known premature coronary or vascular disease and other clinical conditions like eruptive xanthomas, corneal accus in patients less than 45. And the other criteria as depicted above. So there are tests that are needed for one to be able to exclude, because it is important as you see the patient today, able to classify the patient as primary dyslipidemia or secondary dyslipidemia. Important because the cause of the dyslipidemia and the management approach will depend on the costs. Now, to exclude secondary causes, what that means is that this test will help you to know if the cause of dyslipidemia It's a secondary cause of a primary cause. So for diabetes, you can do a glycated hemoglobin. For chronic kidney disease, you check for your urea, electrolytes, and creatinine, and calculate the EGFR. Nephrotic syndrome, you can do a dipstick urine. For liver failure, you do ALT, AST, and gamma GT, as well as albumin. And in cases of hypothyroidism, you may do a thyroid profile, because we know hypothyroidism is a cause of dyslipidemia, because the L-acetyl transferase, L-carnitine acetyl transferase that is responsible for transporting the lipids in the liver is affected by low thyroid hormone levels. Next slide. So these are some of the abnormalities that can be seen in some secondary causes of dyslipidemia, in acromegaly, in chronic kidney disease. Mainly triglyceride that is elevated. So in diabetes, you have all the forms of lipids that are going to be elevated. Likewise in acromegaly, because acromegaly, Cushing syndrome, both of them can have diabetes mellitus. So these are some of the conditions. Okay. So the medications that can cause dyslipidemia include anabolic steroids. Some of those protease inhibitors, even the HIV drugs, mostly protease inhibitors, have been implicated. Atypical antipsychotics, corticosteroids, immunosuppressants, and cyclosporine. Next slide. There are some overlapping features of phenotypic features that differentiate between metabolic syndrome and familial hypercholesterolemia. So mostly apoprotein B is elevated, and also in metabolic syndrome you see decreased level or no normal level of LDL cholesterol. While in familial frequent, you have HDL elevated in frequent hypertriglyceridemia. So how do we evaluate for dyslipidemia? Laboratory testing with biochemical testing is important. Physical, medical examination, and then you must exclude secondary causes, okay? So family history is also important, and sometimes we may do genetic testing. It's not routinely done, but I've had a couple of patients that have had it done. Samples have to be taken to some countries, sometimes in Germany or the UK, to get that done. Now, how does elevated low-density lipoprotein cholesterol contribute to atherosclerotic cardiovascular risk disease? Remember, my colleague who spoke before me spoke a lot about how hypertension contributes to cardiovascular risk, and how other conditions like dyslipidemia and diabetes can also contribute to cardiovascular risk. But for good reasons, elevated low-density lipoprotein cholesterol is usually highly associated with atherosclerotic cardiovascular disease. Now, this slide just shows the timeline of progression of atherosclerotic cardiovascular risk from phase 1 to phase 2 to phase 3, where you have initiation, then progression of the disease, and extensive lipid accumulation. Initially, it's unstable, then later becomes stable in atherosclerotic cardiovascular disease. And we know that elevated low-density protein cholesterol leads to development of atherosclerotic cardiovascular disease, and that can affect the heart and the brain. So it can lead to myocardial infarction, and it can lead to stroke. Atherosclerotic cardiovascular disease on its own is the leading cause of cardiovascular disease mortality and morbidity, with more than about 9 million people dying from ischemic disease, heart disease, and about 3 million people dying from stroke, and about 0.5 million people dying from peripheral arterial disease. Globally, more than 20 million people died of CVD in 2015. Now, cardiovascular disease encompasses a heterogeneous group of diseases. So both atherosclerotic and non-atherosclerotic, both of them are described as cardiovascular disease. But for this presentation, we are going to place much and more emphasis on atherosclerotic cardiovascular disease, which include coronary artery disease, ischemic heart disease, and coronary and cerebral artery disease, as well as peripheral artery disease. Studies have shown that sustained lowering of low-density lipoprotein cholesterol can modify the course of atherosclerotic cardiovascular disease. So there's an almost linear relationship between the levels of LDL cholesterol and the risk of myocardial infarction. Now, like I showed in the previous slide, lowering LDL is directly leads to significantly improved cardiovascular outcome. So a large meta-analysis demonstrated that there's approximately 20% risk reduction in major cardiovascular events for every 1 millimole per liter reduction in low-density lipoprotein cholesterol. Next. So why do we need to do risk stratification for patients? Risk stratification ensures that we're able to monitor the numbers of the patient to move beyond cholesterol numbers to assess globally the general cardiovascular risk of the patient, to ensure also that there's appropriate treatment, and also to intensify or modify the treatment based on the risk of the patient, and to ensure that the patient's outcome improve by targeted therapy. And it also helps us to avoid over-treatment in low-risk individuals and also in under-treatment of high-risk individuals. Now, cardiovascular risk stratification matters because cardiovascular risk varies widely among patients, even with similar low-density lipoprotein cholesterol. For instance, if a patient has a low-density lipoprotein cholesterol of 3 millimole per liter, that patient may not have the same risk with another patient that has 3 millimole, because another patient could have diabetes, and while the next patient may just be obese without diabetes, while another patient could have a high LDL and diabetes and obesity and probably maybe and hypertension. So the risk stratification is not the same for different patients. So the risk stratification is important because multiple comorbidities can exist differently. And we know that there are modifiable cardiovascular risk factors, and part of them include behavioral factors such as tobacco, high alcohol consumption, unhealthy diet, low physical activity. We also have the metabolic, which include diabetes, hypercholesterolemia, obesity, and then others like CKD, psychosocial factors. Then the genetic factors that are, then you have non-modifiable like age, gender, ethnicity, and genetic factors. Now, the major risk factors include systemic arterial hypertension, dyslipidemia, diabetes, and then you now have minor risk factors that are modifiable, include overweight, obesity, and sedentary lifestyle, alcohol consumption. Okay, so these are the risk factors that our intervention can help to modify in terms of outcome of the cardiovascular disease in patients. Next slide. So from dyslipidemia to atherosclerosis, we look at the risk factors of the patients, and we see quite a number of the risk factors are modifiable, and things like dyslipidemia, diabetes, hypertension, okay, and then also the disease conditions like atherosclerosis, coronary artery disease, and you also have the end product of this atherosclerosis, which is stroke, ischemic heart disease, and peripheral arterial disease. So if you look at the picture on the slide, you will see that reduction in these risk factors can affect adverse outcomes like coronary artery disease, cerebrovascular disease, and peripheral arterial disease. Okay. Now, like I mentioned earlier, these studies are different studies that looked at outcome of treatment with different products of anti-lipid products. You can see PRA here is pravastatin. You can see ATX, atorvastatin, SIM is simvastatin. So all these are outcome of cardiovascular trials of lipid reduction, and you see that there's an almost linear relationship with cardiovascular event and lipid lowering, LDL cholesterol lowering. Next slide. This also is showing almost the same thing with the previous slide, and you can see that there's an inverse relationship between the low density lipoprotein cholesterol and the 5 years secondary prevention. This is outcome of 5 years secondary prevention trial. You can see that there's an almost inverse linear relationship between secondary preventive trials, primary preventive trials, and cardiovascular outcome. Next slide. So there are so many risk estimation tools, but I have decided to pick 3 important ones that are used globally. You have the ACVD risk that is used in the US, and you have the score 2 and score 2 that is used in the Europe. The one that I've had some experience working with is the Q-risk score. Q-risk was derived in the UK, actually at Oxford, where the UK PDS trial took place. So they use the data for the UK PDS, and this is how the Q-risk score was derived. So it's account for additional variables like ethnicity, mental illness, and social deprivation, because quite a number of the population were from ethnic minorities, and Africans were also included. Next slide. So what is the LDL target based on the recent guidelines? In the recent guidelines, for example, in the ESC guidelines, they are talking about the risk stratification is when you have a cholesterol, low density lipoprotein cholesterol, less than 1.4, very high risk. The high risk is 1.8 millimole per liter, and then you have moderate risk less than 2.6 millimole per liter. Then you have low risk less than 3 millimole per liter. Additional goal is in very high risk population, you want to achieve more than 50% of the baseline millimole per, LDLC. For instance, somebody who comes with LDLC of 5 millimole per liter, you will want to achieve 2.5 millimole per liter in that patient. So that may go for an intensive therapy. So this slide shows just an algorithm of how to approach management of dyslipidemia, and the patients are supposed to assess risk. This is in terms of primary prevention. No, sorry, I need to reemphasize that for patients who have had cardiovascular risk, their approach is for secondary prevention. So they have had the primary events. So those who have had the prior MI, prior stroke, or peripheral arthritis, those are treated as secondary prevention. But for primary prevention are patients who have never had any event before at the time of risk stratification. So this slide helps to identify the patients and also how to risk stratify them, which you could go through them once it's shared. So the management approach to dyslipidemia is to assess overall cardiovascular risk using validated tools like the Q-risk, ACVD plus, and the one that is used in Europe. And then it is important to rule out secondary causes of dyslipidemia ab initio. That's why I took my time to talk about secondary causes like the hypothyroidism, nephrotic syndrome, and so on and so forth. And it is important to also define the LDL cholesterol target for risk stratification. And the first thing to do is to initiate lifestyle intervention in all the patients. And then pharmacotherapy is needed if the target is not reached. And at risk stratification, patients who are at high risk or very high risk are supposed to be initiated immediately on pharmacotherapy. You don't need to start lifestyle modification at that point. You need to go to pharmacotherapy. And you need to also monitor lipids and adherence, and then reassess the risk of this dyslipidemia periodically. Some people say 3 to 6 months, and I think it's good, it's fine. Next slide. So lifestyle modification is usually the first line of therapy for people who have moderate to high risk, but for very high risk, I will mention again that you need to start treatment very early, because the risk includes atherosclerotic cardiovascular disease, pancreatitis, and so on and so forth. So they are expected to adopt a healthy lifestyle, especially the Mediterranean diet, or what is described as DASH, dietary advice to stop hypertension. Now, they are also to limit saturated fat intake to less than 7% of their total calorie, and they are encouraged to engage in aerobic exercise for about 150 minutes per week, and that goes to about 50 minutes alternate daily or something. And then weight is expected to be maintained to about 25 kg per meter square. For those who are taking cigarettes, they are expected to stop cigarette smoking. And then alcohol, they have to reduce alcohol intake, because alcohol also is a cause of secondary dyslipidemia, and alcohol does modify lipid metabolism. And dietary supplements like plant steroids, soluble fiber may help. Now, this slide shows the different targets and drugs for different levels of dyslipidemia. But the slides on red is showing very high risk population. So in this group, you start lifestyle and concomitant drug therapy. So you look at low risk. In low risk, you start when the total LDL cholesterol is less than 1.5. You can start on lifestyle, and then when it is between 3 to 4.9, you go for drug therapy. So on the yellow group, it's indicated that you start drug therapy, but for the red, it's directly, direct drug therapy. But for the green, you go for lifestyle measures initially. Next slide. So this next. Okay, so pharmacological options that are available for treating dyslipidemia include statins. We have so many of them: rosuvastatin, pravastatin, simvastatin, fluvastatin, and so on and so forth. The next group of drugs are the ezetimibe. Ezetimibe is an add-on to statin, and sometimes you can see some drugs combination of statins and ezetimibe and so on and so forth. The next is PCSK9 inhibitors. So these are drugs that are very, very good. I think PCSK9 is pro-converting subtilism kerosene 9 protein that is known to be affected in some form of familial hypercholesterolemia. You have bempedoic acid. Bempedoic acid is also good. Then you have fibrates. Fenofibrates are also good, especially in patients who have very high triglyceride levels, but not necessarily for LDL cholesterol. But sometimes we may need to combine some of these drugs. And then omega-3 fatty acids. They are used in selected high-risk population with hypertriglyceridemia, and sometimes in pregnancy where you may not want to be giving statins to patients. Next slide. Now, hyperlipidemic drugs act through different pathways, like I've showed to you in the liver. The statins are also called HMG-CoA reductase inhibitors. They prevent this rate-limiting step enzyme of cholesterol synthesis, hydroxymethyl coenzyme A, from functioning. So the newer drugs that I have not mentioned include things like CETP inhibitors, and then you have anacetrapine and evacetrapine. So these are the new drugs. But remember that I've mentioned fenofibrates. They're also very, very good in reducing triglyceride levels. Nicotinic acid is also used, but we don't use it. Next slide, we can continue. This slide shows, it's a bit crowded actually, but this shows the management approach for primary caregivers, because we were told that this presentation will be for primary caregivers. So you should reassess the patients in 3 months. Once you feel that the target is not reached, then you go back. Like I said earlier, you assess the patient. Does he have a prior cardiovascular event, MI, stroke, peripheral artery disease, or familial hypercholesterolemia? If the answer is yes, that means that this patient is going for secondary prevention. But if the answer is no, the patient is going for primary prevention. Once you assess the patient, then you determine this patient, if he has had an event before, that already qualifies him to be a high-risk group, so you are going to start treatment immediately. But if he has never had any event and the total LDL cholesterol level is not that high based on the criteria I've given, you may start from lifestyle measures. But if it is high, very high, then you need to start pharmacotherapy immediately. Next slide. So these are the guidelines for European Society for Cardiology, and you can see they define you do a total cardiovascular risk assessment for the patient. Once you do a total cardiovascular risk assessment, you obtain the baseline LDL-C. You can either go for lifestyle medication and intervention, which include medications. You continue with high potency statins. Once you are not achieving target on high potency statin, you can add a PCSK9 inhibitor. The next slide. Now, there are evidence that have shown that these statins trials, the statins are very good in both primary and secondary prevention. Next slide. But you know, again, it has also been shown that sustained lowering of LDL-C cholesterol can modify atherosclerotic cardiovascular disease years after, treatment. Next slide. This is just to buttress what I've mentioned earlier, that the risk reduction of coronary heart events is higher with this is just talking about the PCSK9 carriers, and those who have the genetic PCSK9 carriers still achieve reduction in cardiovascular events when LDL-C cholesterol is reduced. Now, I've mentioned that earlier that meta-analysis have shown that 1 millimole per liter reduction of LDL is associated with 20% reduction in cardiovascular events. Next slide. Now, the LDL low density lipoprotein cholesterol reduction is part of the 2019 ESCDA recommendation for primary and secondary prevention. So subsequently, these have been modified. But like I said earlier, when you have a very high LDL-C representation, you target for 50% reduction from baseline. For instance, somebody has 4, and you have to target up to 2. Okay. After the initial risk stratification, initiation of therapy, and the initial lipid panel at baseline, you are supposed to check this lipid panel in 6 to 12 weeks time. Most times we do it after 3 months in this part of the country, this part of the world, sorry. And you are also expected to assess adherence. For instance, some of the medications can have side effects, like statins can cause myalgia, they can cause myoglobinuria, they can cause sometimes abdominal discomfort, and some patients may not tolerate them. That's what we call statin intolerance. Some of the other drugs also have some side effects. So the patients may not be adherent because of some of the side effects of the drug. And once the lipid panel are stable, you can follow them up for annually. You use your clinical judgment to escalate or de-escalate therapy based on the risk, and you reinforce lifestyle intervention at any time that the patients come for the follow-up visit. Next slide. So despite all these things that we have said, it is actually not easy for patients to reach target, because one of the problems that have been noticed globally, not only in this part of the country, is that less than 50% of these patients reach target. And this is where our responsibility, our role as healthcare givers, as doctors, nurses, and healthcare providers, even pharmacists, are, because we need to ensure that these patients keep they adhere to their medications. Apart from the adherence, they also maintain target, because if you are able to maintain target, then you are comfortable that their risk for cardiovascular disease is going to be reduced. But as long as we are not able to make them to achieve target, to make them to be adherent is difficult. So studies have shown that only 54% of patients are able to attain target. And these studies are studies in places where things are done differently. I'm sure by the time we take our data in our environment, I'm sure those that are achieving target are going to be less than that. So I would challenge my other colleagues, the primary care physicians, to look at the data, and we can do a national survey to look at the patients, a retrospective study, and see after a period of time, maybe 1 year, how many of those patients were able to reach target. And we can report that, because I'm sure the statistics will be, awful. Next slide. So medication burden impairs adherence. Like I told you, sometimes because these patients have diabetes, hypertension, dyslipidemia, they need to take a lot of drugs. And when these medications come, we are giving them 2 different anti-lipid agents that may affect adherence. So this is the reason why I'm going to introduce this new drug to you. And unfortunately, I think one of the slides is missing, but notwithstanding, I'm sure that we are going to be talking about inclisiran, and inclisiran is some of those new molecules that came through this new technology of small proteins. You know what RNA technology has brought when COVID-19 came in terms of diagnosis, in terms of treatment. So this inclisiran is an RNA, single RNA molecule that can cleave many RNA transcripts that is now useful as one of those latest anti-lipid agents. So what is inclisiran? Inclisiran helps to lower low-density lipoprotein cholesterol, LDL-C. Next slide. And LDL-C is mainly regulated by the level of, LDL-C is mainly regulated by the level of, by the LDL receptors that are found on the surface of hepatocytes. And these LDL that are receptors that are found usually bind this lipoprotein cholesterol and internalize them into the hepatocytes. And that internalization can lead to transportation of those drugs. But certain proteins like PCSK9 synthesized in the liver interfere with the regulation of these lipoprotein receptors. So that is how PCKS9 inhibitors, prochromatin subtilizinase 9 inhibitors were actually designed. Next slide. So I'm particular about inclisiran because it's a small molecule that acts in the hepatocytes in the liver to interfere with the metabolism of the fat, and it prevents the production of this PCKS9 protein by degrading its mRNA. So you see the initial drugs that were PCKS9 inhibitors, I know this is an innovation over that initial drug design. So this is how it works. And it enables, because of the mechanism of action, there is this GNAC that conjugates with inclisiran that helps to the hepatocytes to take up the inclisiran very fast into the hepatocytes. And that is how it's been. And we said previously that PCSK9 protein helps in the function of the lipoprotein receptors that are found on the hepatocytes that help to internalize this lipoprotein. So the initial drugs that were PCSK9 inhibitors like what we call avemurcumab, now you have inclisiran that prevents the protein PCSK9 inhibitors from being produced at all. So, and this inclisiran is actually initiated as an injection. It's actually given as an injection the way you give your subcute low molecular weight heparin or growth hormone and so on and so forth. Some of these protein medications, and it is administered usually initially at presentation, then after 3 months, and then you give maintenance doses every 6 months. So the major problems may be some skin reactions, which is usually mild and transient. So with 2 doses per year, this drug can help to sustain your cholesterol level to very good levels. And I've used it in a couple of patients. Aside from the cost, I mean, it has been very, very, very good. Patients that have used it have reported very good results. So it is well tolerated with good safety profile. And I'm aware that there are some cardiovascular trials that are ongoing, but I've looked at some of the previous trials, Orion 9 and 10, and the report has been very, very good. There is none that has reported severe adverse effects so far. So the clinical application, I mean, I've looked at one of the patients that we gave. This is the patient that took inclisiran, and we followed his lipid after 6 to 12 weeks. And then he was initially at 145 milligram per day. Next slide. Oh, sorry. One of the slides is missing. But he had a a very good reduction, because from 145, I think after 6 months, the patient came down to around 80 something, and our target was less than 70. So we still were waiting for the patient to see at 1 year what level of lipid. But for this patient, you know, we should target around 50% reduction, and I'm sure this patient has done well to even get to the level of 80. Next slide. So to summarize, dyslipidemia should be risk-based, not cholesterol-based alone, because you look at the individual patient, the total cholesterol and other risks in terms of diabetes, hypertension, cardiovascular risk factors. Somebody may have high cholesterol level, but low risk for diabetes, low risk for hypertension, low risk for obesity. Now, appropriate tools should be used to stratify cardiovascular risk, and this is an area that we should be interested in. What are the tools that are good for our population? I prefer to go with the UK tools QRI score, because I feel quite a number of our population are more in the UK group population that were studied to drive that risk than the European and the American. But that doesn't mean that we cannot have our own risk tool to be able to stratify our population. But it also means that we need to collect a large data to be able to do that. Lifestyle changes and medications are indicated, but you should also remember now that at presentation, when the risk is very, very high, you go immediately for pharmacotherapy. But when the risk is not that very high, you can initiate lifestyle measures, then you go to pharmacotherapy. And you monitor and adjust therapy accordingly. So this is just to summarize what I've said, then to also mention that inclisiran is the first and only small RNA protein that utilizes that mechanism to increase LDL receptors in the liver, and also through the PCSK9 protein to help in LDL-C cholesterol lowering. I thank you very much for listening, and I hand over to my host, Novartis, for this program to continue. Thank you.
Yeah, thank you very much, Dr. Ramalan, for that presentation. So we are now time for our questions and answer session. Yeah, I think I saw some questions already on the chat box, and I think Dr. Ajikun has addressed some questions. So if you have any questions, you can raise up your hands and we acknowledge you, and you go ahead and ask your questions. Or if you don't want to do that, you can still put your questions on the chat box. We'll read them out for our speakers to address them. Once again, thank you for both speakers, Dr. Ajikun and Dr. Ramalan. Thank you very, very much. So I see a question about the cost of inclisiran in Nigeria. So for this presentation, we're not about the cost. We're just here to share about the science of the molecule, for us to know that there is something called inclisiran in the management of patients with elevated LDL-C. So if your patient has been on statins and they're not doing well on statins, and you believe that they need another option, inclisiran is there available for you to use.
Hi, Osi.
Yes, please.
I think if you go to the chat box, there are some questions there.
So I'm trying to go through scrolling upwards. Yeah. So I saw one question about meltidopa is essentially acting antihypertensive. It can be used. Okay, that's the answer, but not as first-line agent. So what are the things to consider in commencing pharmacotherapy for hypertension? Does age affect the blood pressure level at which pharmacotherapy should be commenced for patients with hypertension? I think that question, Dr. Ajikun, if you're still here.
Yes, I'm still here.
Okay.
Thank you for the question. So as I indicated earlier on, for you to initiate blood pressure and then the level at which you initiate therapy, you need to risk assess the patient. So in risk assessment, the age of the patient matters, and as well as the other comorbidities that the patient has. Does the patient have evidence of left ventricular hypertrophy on the ECG or echocardiogram, that the patient have renal evidence of renal impairment like proteinuria and things. So you have to put all of them together. Definitely, the how do I call it? The frailty of the patient also matters. If that patient is an 80-year-old frail patient, you are not going to be pushing so hard on the blood pressure. So such patients, some of the guidelines will say initiate therapy at systolic blood pressure of 150, thereabout. But definitely putting the patient's total risk assessment into consideration is the way to go. Thank you.
Thank you very much, Dr. Ajekum. Yes, another question also on hypertension. It says, when the routine for antihypertensives are not working, what do you do? And if you have any experience, kindly share.
That's interesting. Well, I don't know what the questioner means by routine for. I gather the routine for will mean ACE inhibitor stroke ARB, calcium channel blocker, and diuretic. Or did the person add beta blocker as part of the routine for? Did the person add spironolactone? The guideline is that your first two agents are either ACE inhibitor or ARB. You don't combine ACE inhibitor and ARB. So ACE inhibitor or ARB plus a calcium channel blocker or a diuretic. Then the second step is ACE inhibitor or ARB plus a calcium channel blocker plus a diuretic. Then beta blockers can be added at any point if the person, for instance, has tachycardia or ischemic heart disease or not. Your ideal fourth agent is a mineralocorticoid receptor antagonist, because aldosterone is one of the main reasons for secondary hypertension. So mineralocorticoid receptor antagonists, either spironolactone, or if the person cannot tolerate spironolactone because of gynecomastia and other side effects, then you go for eplerenone. From there, your subsequent lines depend on what other matters are at stake. You could choose alpha blocker, you could choose a centrally acting agent, you could choose other loop diuretics. For instance, if the person has CKD, EGFR is less than 30, in those patients, loop diuretics also work very well, in addition to your other agents that you are using. So further choice depends really on what the person has. I try not to use centrally acting agents too quickly, because especially for the young men, these are very hard on their performance. So if you introduce them too early, they will stop all your medications and rather have their performance. So it's important that I have realized that a lot of, especially those at the primary care level, tend to write metadopa too quickly. One of the major side effects is erectile dysfunction, and that may discourage patients from taking their medication. So centrally acting agents, yes, they are useful, but they should be used as, like the 5th level or the 6th level when your blood pressures are not well controlled. I don't know whether that addresses the issue. Thank you.
Thank you very much, Dr. Ajekum, for that. Yeah, I think there's another question on the chat. I think this is for Dr. Ramalan. Is there any national guideline for the management of dyslipidemia, Dr. Ramalan?
Well, thank you very much. At the moment, I would say we don't have a national guideline for management of dyslipidemia, but I am aware that some groups, in Nigeria actually, I don't know about Ghana. So some groups are working on it, but I think that we should have a national guideline for management of dyslipidemia.
Okay, thank you very much for that input. Yeah, Dr. Olumayowa, your hand is up. Kindly unmute and ask your question.
Okay, I was the one that was asking the question about the for cash, or that's amlodipine, ramipril, or moderatic was the initial thing that was being given. But later on, when the blood pressures are not controlled, that's spironolactone. But even that, I don't see any difference in this kind of people. So I wanted to share the general opinion. What do they do when things like this happen? Then, okay, I think that's, then why, if you are having like 4 drugs, piling them up and they're not working, does it, I'm just thinking, is there a way that one can just, okay, maybe we'll just sweep all this 4 away and start afresh on new, other or classes of drugs to see whether to get the desired results.
Yeah, Dr. Ajikum, I don't know if you want to respond to that.
Yes, that's interesting. In our part of the world, the other thing we also need to battle with is the authenticity of the drugs that are being prescribed to the patients. Sometimes the source of the drug also matters a lot. There have been instances where you just change just the brand and it does all the magic. So it's important to look at it. In fact, evidence suggests that, and that is what I've seen in my practice. If you get your patient on 3 antihypertensives, about 80 to 85% of them will have their blood pressure on target. The rest, the 15% that is left, is either because they are not taking their medications or because they are not receiving the appropriate drugs, or they have resistant hypertension. So that is what you need to battle with. So we need to really assess compliance. Is the person really taking those medications? If they are single agents, I'll recommend that you do a single pill combination therapy to improve compliance with the patient. And then assess ambulatory blood pressure to see, is there white coat effect? Maybe the person coming to the hospital, the blood pressure is high at hospital, but when you do ambulatory blood pressure, it's normal. So assess ambulatory blood pressure. Assess for any other secondary cause of hypertension. What are the other things the person is taking? Is that person on chronic NSAID use? Is that person on steroid use? So all those things come into play when you are assessing the patient for why the person is not getting adequate blood pressure control. If after doing all these things, it is just pure resistant hypertension, the addition of these agents we mentioned, beta blockers, alpha blockers, centrally acting agents, become necessary. If despite all these things, the person is not responding, this is where the range of renal denervation also becomes important. But at this stage, it is not the first line therapy you are going for. It is when you have really ensure that that person is compliant and the resistance is true resistant hypertension. Thank you.
Thank you very much, Dr. Ajikum. I believe Dr. Ramalan has something to add.
I'm
Dr.
trying
Ramalan,
to
unmute.
Okay, trying to omit my mouth. It's just to I quite agree with Dr. Agekum on the source of the drugs, because apart from the brand, I mean, in terms of logistic storage and transportation of these drugs, they can actually affect their potency. And then one thing I've learned from some of my colleagues who in nephrology is that sometimes we don't give the, sorry to say this, the non-nephrologists.
Sorry, Dr. Ramalan, I think we can't hear you anymore. Can you hear me, Dr. Ramalan?
I can hear you, but I'm trying to unmute my microphone.
You can go on now, it's fine.
I was trying to unmute my microphone. Can you hear me now?
Yes, it's better.
Okay, I said one thing that I've learned over time is that we hardly give sometimes the maximum doses of some of those medications. So somebody that is not taking a maximum dose of a particular drug cannot be classified as having resistance to that particular drug. So if somebody who is taking 5 milligram of amlodipine is not achieving control, and we add another drug, we add suboptimal doses. So we need to ensure that they are taking the maximum doses for us to qualify them that as being resistant. And then to also ensure that they are actually taking it, they are adherent to it, because sometimes the patients themselves don't take these drugs regularly. And finally, we should not forget endocrine causes of hypertension like thyroid disease. They are a little bit common, and there are other reasons why patients may not be on target, not necessarily because the drugs are not sufficient. So we need to take these factors into consideration. That's just my contribution.
Thank
I
you
hope I
very
was
much.
audible.
Yeah, it's fine. Thank you very much, Dr. Ramalan. Yeah, before we continue, yes, I think a link has been dropped on the chat box. Please kindly go through the link and give your feedback. We'll appreciate your feedback on this presentation. I think I have one more question on the chat. Is that at what point or drug therapy would you recommend a patient be transferred or referred to the specialist center from a primary care level for the management of hypertension? I will hand this over to Dr. Ajikum.
If you have that patient on maximum doses of 3 antihypertensives and the blood pressure is still not controlled, it is time to refer the patient to a hypertension specialist.
Straight to the point. Thank you very much, Dr. Ajikum. Do we have any other question? Good. So I think with that we can come to the end of today. Yes, please.
I think we missed one question. There's a question.
Yeah, go ahead. You can go ahead and read it.
Mr. Ayuba, it says, thank you for both presentations. What is the safety profile of statins?
Okay, so that will be for Dr. Ramalan. Okay, thank you very much for this question. They are actually quite safe, but some patients don't tolerate statins. Like I said earlier, there are some side effects like myopathy, body aches. They can cause rhabdomyolysis. They can cause tendinitis. They can cause constipation. Those are some few side effects, but some people don't tolerate them. And statin intolerance can take place even with minimal doses. So it's not a dose-dependent activity, but they are relatively quite safe. But like not every drug is completely 100% safe. Thank you very much for that, Dr. Ramalan. So that we don't take too much of our time, we'll be rounding up at this point. So I will hand over to my colleague, Bifi, to give us the closing remarks.
Yeah, thank you, C. First to say a super thank you to our faculty for the day, Dr. Jakum and Dr. Ramalan, for making yourselves available and of course sharing your expertise with us, the rest of us, sharpening our skills and so on. Also want to say a big thank you to our attendees for making yourselves available to upskill and to benefit from the updates. Ultimately, it is our hope that it impacts on our practice and the service that we deliver to our clients. Also want to pass a reminder that we have a session tomorrow as well on 2 other non-communicable disease topics that are relevant for our practice to help us serve our patients better. And we look forward to meeting you tomorrow as well. Thank you and have a good evening.
Thank you very much, everybody. Bye for now.
Thank you.
Bye.
Bye.
you.